Yet, over to you, sir.
Thank you very much for the kind introduction. Uh, Moving on, the diagnosis of diabetic nephropathy relies on detection of albuminuria and decrease in the eGFR. And the decline in the eGFR is a consequence of renal function loss and destruction of the glomeruli. And albuminuria is the strongest predictor of the end-stage renal disease and cardiovascular mortality. What is important out here is that when the GFR moves towards left hand side of 60, you can see there is an exponential rise in the cardiovascular mortality and end-stage renal disease. So this is a routine thing. What do we evaluate for kidney function in diabetics? We usually do a serum creatinine and a urine protein excretion. And this is a nice little illustration showing us the relationship between serum creatinine and the GFR. What is important out here is that the eGFR of around 60, the serum creatinine still appears to be normal. Now let us look into two different case scenarios. A 56 years old type 2 diabetic with liver and then having a creat of 1.4 milligrams. And then again, we have a type 2 diabetes. He's a bodybuilder, but the creatinine is same. In the first case, you will see there is a 50% decrease in the kidney function. And in the second case, there is no abnormality of the kidney function. So these are the non-GFR determinants of creatinine, that is gender, race, nutritional status, protein intakes, drugs which are affecting the tubular creatinine secretion. But the most important one is the diseases of the skeletal muscle. And to overcome this, we have the cysteine C, which does not seem to be affected by, or it is less affected by these non-GFR determinants. It is more sensitive, it is more accurate. And there are studies which have shown that cystatin C is much more present or much more early detected in eGFR above 60. And the GIDGO says that if the assay is available, then you need to do both the combination. You can use combination of two biomarkers. Now, this is an app this is a calculator. I'm quite sure each one of us would be using one possible calculator out here. The important part is that the equations may either be underestimated or overestimate the GFR and DKD due to compensatory changes in the nephrons. And there is a reduced utility of these calculators in patients with normoalbuminuric phenotype. None of these equations have been validated in India. The important part about this measured GFR is that the accuracy and precision. Accurate measures of GFR in the early stages of kidney disease prior to stage 3, that is stage 1 and stage 2. And it can easily identify early GFR changes such as rapid decrease in the levels, which may be a sign of diabetic kidney disease, which serum creatinine or the eGFR cannot. So microalbuminuria remains the gold standard marker for detection of diabetic nephropathy. But having said that, not all diabetics will proceed to end-stage renal disease. 30% of them will actually have normal albuminuria. And microalbuminuria is also present in once the significant renal injury has occurred. The ADA says that we need to check for evaluate the patient at least 2 out of 3 times if within a period of 6 months. If it is positive, then the patient is considered to have microalbuminuria. But the problem is that what about those individuals which are having normal albuminic diabetic kidney disease? Albuminuria can be reversible. It often occurs after the development of low eGFR, and there are conditions which affect the increase in the urine albumin excretion. This is the Morgensen staging, and why it is important out here is because there is a clear relationship between the extent of structural damage and renal function, which tells us about the onset of clinical stages, and that is usually stage 3. And it does not, it is less apparent in the initial stages, that is stage 1 and stage 2, which are considered to be preclinical stages. Hence, we need biomarkers out there in order to figure out what is happening in the preclinical stages. So the kidney injury is a continuum. It is always in the continuous process. And just like renal biopsy, we are talking about fluid biopsy out here. In order for early detection of this particular kidney stage disease and prognosis, prediction of the response to therapy and monitoring the response, thereby preventing our patients from undergoing the end-stage renal disease and cardiovascular mortality. So these are the factors which play a very important role as far as the pathophysiology of diabetic kidney disease is concerned. But they all contribute to what is known as glomerular injury and tubular injury. And there are a number of biomarkers which have been, which tells us about the glomerular injury and the tubular injury, inflammatory markers, and the marker for oxidative stress. The story is ending, I would say, unending. I would say it just continues to develop out there. And based upon the site of origin. There are papers which have shown that they are based upon the site of origin. You can have biomarkers. You can have biomarkers depending whether they are useful for diagnostic purpose or therapeutic response or prognosis purpose. And there are papers which have also shown that we are now moving to omics, which is considered to be proteomics and metabolomics. So that is, we are targeting personalized treatment, or we particularly look into individualized treatment to give them personalized treatment. Now, this is the overview of the various biomarkers. And when we look into the glomerular part, the type 4 collagen seems to play a very important role. In the tubular part, the neutrophil gelatinase associated lipocaine and the kidney injury molecule 1. And then in the inflammatory marker is tumor necrosis factor alpha and the TNF alpha receptor 1 and 2. And then we have the interleukin 6 and the vascular endothelial growth factor. Now, what about the biomarkers for non-albumuric diabetic kidney disease? And we have the alpha-1 microglobulin, which is much more stable as compared to the beta-2 microglobulin. We have the nephrin, we have the MMP9, and the immunoglobulin. Moving on to proteomics, based on upon the GWAS, these are various chromosome loci where you can, which have been associated with diabetic nephropathy. And then we also have the proteomes, which is a collection of all proteins present in the urine originating from different sources, whereas the urinary metabolome refers to the complete set of small molecule metabolites found in the urine. And there are various, these omics are basically urine based. We can have a single panel or you can have a multiple panel testing out with respect to a biomarker. And then if we use non-invasive biomarker, which is in the urine, we can have a protein based biomarker and peptide based biomarker. These are the urinary based biomarkers which are actually present or help us with respect to type 1, type 2 diabetes. They are usually present even before the initial stages of albinuria, and they can also help in predicting microalbinuria. And these are various studies which have shown that the kidney injury molecule 1 seems to be doing a very, apologies, I think it's not seen. The kidney injury molecule 1 seems to play a very important role in identifying these particular the stages of early progression of diabetic nephropathy. Now this is CKD 273. It's a panel of around 273 peptides, and it has been serving as a very important early risk predictor for deteriorating kidney function, guiding intervention at very early time of disease before even the DKD is manifested. It is commercially available abroad, not in India, but it helps us to, it actually tells us whether an SGLT2 versus an MRA, whether a ARB or whether DPP4 inhibitor is particularly going to be helpful in a patient. We are moving on to biosensors. Lots of them. There are lots of advantages. They are saying that they are market independent, sensitive, stable, easy to use, cheaper. But these are all in the earlier stages. And then we also have what is known as a machine learning enabled prognostic test for patients. That is the Kidney Intel X for type 2 diabetes and CKD. And they basically classify the patients into low risk, moderate risk, high risk, and very high risk. So the question is, are any novel biomarkers actually being used yet? And despite the availability of the novel biomarkers, I would say the evidence for their usefulness remains variable and controversial. And biomarkers do not replace the conventional test and adequate clinical evaluation. They basically help us to, they are just serving us as a complementary test. Thank you very much.